This conference will now be recorded.
I feel like I'm in the department store. You know, I look at the numbers and I'm saying going up. It sort of gradually increases. All right, so we'll start off from the top. Jake, anything you'd like to talk about?
Well, I'm not going to get a PSA until June, so I am a little bit nervous about that. But you know, other than that, no news.
Well, we can talk about that because there may be other people in your who are in your same situation, and it's a good topic to talk about today, obviously. Russ, anything you'd like to talk about today?
Nothing that's pressing. If we have time, I may be able to wade in on a couple things, but yeah, I'm just waiting to start the radiation in 3 weeks.
Okay, so we'll see how we do. I've got you as a yes, maybe.
Optional.
Mr. Finn, welcome.
Hi, how you doing?
Well, where do you live? Aren't you in Kansas?
No, not that I think. Dorothy's there, but not me. No, I'm in Chicago area.
Oh, Chicago. Okay. Would you
I got-
like
got
some
people-
time to speak
I
to
got
us?
people upside down and sideways.
Mark, would you like to talk to us tonight? Take some time. Mark,
Yes.
would you
I'm
like
sorry,
some?
Kenny. Yeah, sure. Just a few minutes. That'd be fine. I can give you an update on my situation.
Absolutely. Leonardo, anything for you?
Well, if you need some to avoid some dead air time, Bill Franklin and I were exchanging emails about radiation proctitis. I wouldn't mind asking the guys if anybody has any experience with that and what they've done.
Oh yeah, well I do too. So yeah, definitely.
I don't know, Lynn and Rick. I think we might be the pros. So
Yeah.
Yeah.
unfortunately,
Yeah, I'd rather be an amateur, to be honest, but I don't know about you.
I agree.
Ken Anderson, anything for you?
Nope, I'm good, thanks. I'll just listen in.
Okay. Peter, anything you'd like to talk about?
Yeah, I'll give you an update about the intersection of coronavirus and chemo.
Okay. Dennis Correa, anything for you, Mr. C?
Yes, give me about 5 minutes, kind of on maybe on the same subject, or close to the same subject that Peter and has talked about, coronavirus and the ongoing treatments and stuff.
Okay. Well, I've got you and Peter next to each other, so the two of you can share that time. Jerry, anything you'd like to tell us from San Carlos?
Well, you'll be interested to know that in our state of Sonora, we are locked down. There's no liquor. You've got to stay in your house. They've stopped all the construction workers from constructing. It's like a ghost town. But anyway,
Really?
I'll probably add in on that PSA because I don't get it until June also.
Okay, fine. Yeah. All right. Yeah, I think we've got a few common topics today. Mr. Fish, who is definitely locked down in Brooklyn. How are you? Are you there? Larry? All right, we'll come back to Larry.
Because he logged off once and came back on again, so he might be having phone problems.
Okay. And we see somebody joined us by telephone. Who is that?
Hey, Rick, it's Dennis McGuire. Joined a few minutes late.
Hello, Dennis McGuire. Okay, I'm adding you to the list. Dennis McGuire. Where was I? Calderon, anything for you?
Yeah, I'll give a quick update.
Sorry, anything for you, Les?
Nothing today, thank you.
Pleasure. Now Larry's with us. Larry, are you with us this time?
Yeah, I couldn't get sound to work from my smartphone. I don't know why.
Oh dear, it isn't such a smartphone, Larry.
Maybe it's not the phone that has the problem.
Okay.
We also lost Dennis McGuire. I don't know what happened to him. Somebody else is on the telephone. Is that you, Dennis?
No, Dennis is still on, and I'll give a quick update, Rick.
Yeah, I had to sign in on the computer, which, by the way, is annoying. If you go through the website, I'll tell you, it's kind of annoying. And then call in by phone. That's how I'm here now.
Oh, well, it should be one click. When you...
No, it's like, first of all, like, who are you? Put your name, then something else, then connect your audio, enter the meeting, enter the code for the meeting in order to use your phone, enter the audio pin.
No, you're not doing it right then. That's what I thought. You've just got to click on the link. You just have to click on the Ancan Barniscus link and it'll bring you right in.
I know that's what happens on my phone, but that didn't happen on the computer. Anyway, I don't want to do this now.
Okay. And how are you in New York there? Because that's
okay. I came upstate to see a dentist. But New York is in Brooklyn, southern Brooklyn. It's kind of been scary. It can feel like illness and death in the air, really. When you go out, everyone is pretty careful, and then some people are completely irresponsible at the same time, and everybody's panicky, and it's weird. It's really weird. Now it's easing up. Anyway,
have you lost anybody that that you know, Larry?
Yes. Yeah.
I'm sorry.
That's okay. A couple of my teachers, one of them is like still struggling, and one is just getting better.
Okay, well, you stay safe, for goodness sake.
Yeah. Thank you.
Sylvester, anything you'd like to talk about tonight?
No, thank you.
Okay. And Peter, anything for you, sir?
I just had a quick question about the side effects of the bone density medication Fosamax. Just had a question about that.
Okay.
That's it.
And Bill, anything other than the radiation proctitis?
No, I'm doing good. Everything's fine over here.
Okay. And then somebody look, oh no, it's not, it's Mark. It's Mark back on a different machine. Okay, I think.
Rick, we still have someone on the phone. I think Dennis McGuire dropped off. No, I don't think so. He was caller too. Are you still with us, Dennis McGuire?
Yes, I'm still on.
Okay. Okay. You must have been logged on twice somehow.
Okay.
Gotcha. Thank you.
Okay. And I've got you down, Dennis, to speak. All right, let's kick off with a couple of these common topics, because I think it'll knock out a few of you gents that have questions and concerns. Let's start with Jake's concern, which is a very viable one for men with advanced disease, about deferring your PSA. Go ahead, Jake.
Hang on, I'm Bill Franklin, I'm muting you. We're getting noise from you. Yeah, I just, because of the concerns of the COVID-19, I have not been getting my monthly Zometa shot. And of course, then I'm not getting my monthly PSA test. So in February 28th, it was 55 and going up. And so I'm quite nervous. And I deferred all my appointments until June because I have to get a Lupron shot in June. I don't think I can skip that. I haven't asked my oncologist that, but I don't think I should skip it. So in the meantime, my PSA is probably going crazy. I'm just a little bit nervous, or going a little mental, as Ken might say.
Just give us the last 2 or 3 months for the gents, because I think I have it recorded, but just give us the last recent history that you have there of your PSA.
I'll have to check. Hang on.
Rick, while Jake is looking that up, I'll be here for just a little after 6 Central Time. Then I have something else I have to run off to. So
okay,
if you want me
fine.
to give an update at some point, I'd be glad to do that.
We will definitely. I'll definitely come to you. So I know. So you've got about 40 minutes, right? Right, Mark?
Yeah, something like that. I'll try to stay as long as I can.
We'll definitely stop by. Thanks for letting me know too. Appreciate it. Go ahead, Jake.
Okay, well, it's been going up since May of last year, progressively going up. You know, I started apalutamide, and that doesn't seem to be doing anything. And it's right now it's gone from 8.8 in May of last year. It's now 55. Each month going up a little bit more.
Okay. So and
some of that time I was on Abiraterone.
Right. And Jerry, you also had concerns about the about your PSA timing, correct? You're muted, Jerry. You're muted.
Sorry.
Go ahead.
Sorry. At this time, I really don't know. I'm supposed to be, you know, at least 0.05 or 0.04. And I was planning on having my PSA done here. But now we're all locked down, so I can't. And I did find out from Mayo that I can't set up my appointment for the first week in June until the last week in April. They evidently go on a month-to-month basis for setting up their schedule. And I need to get my Lupron shot and my Xgeva shot. So I'm a little antsy and a little anxiety about trying to get up to Phoenix and get that taken care of. But yeah, my only concern was I can't get a PSA until I get up there now. So, and I'm a little concerned about how that's all going to happen. So anyway, that's all I had.
So, so we've got two situations here. We've got that have similarities, and then they have big differences. We've got men both with advanced disease, one of whom is doing relatively well in his having the hormone therapy control the PSA, and has been on hormone therapy for, I don't know, is it a couple of years now? It's a couple of years, right, Jerry Pelfrey? You've been on
a year and a half.
Year and a half. And then we have another with Jake where the PSA is certainly on the move. A man who's been on hormone therapy for maybe 8 or 9 years, right, Jake?
2012, yep.
So, and both of them have got shots due in June and PSAs due. Let me throw it out to anybody, any of you brainy guys out there, and tell me what you're thinking. And what would
I want to chime in. I want to chime in with more relative issues.
Please.
So my question is, I'm doing May to go to Sloan for my Lupron, and I ended up canceling one PSA test. I didn't want to travel for it. Subways are kind of crowded with some people with masks, some people without. Can they switch the Lupron shot to a local doctor who's close to your apartment? I don't know if hospitals or places like Sloan would do that, but I used to get it locally. Why not like my local doctor's office? I can explain how to give the shot if they don't know. I don't know what their, protocol is, but certainly would be helpful just to go around the corner to
Larry,
5 blocks away. Yeah.
Larry, any urologist or oncologist can give you a Lupron shot.
Right, but
I don't know about a PCP, but I know urologists give them all the time.
Right, and a prostate test is nothing. I've even pushed a PSA test. I've even pushed one of those myself at a local place. So can we get our doctors to just stop making the extra $500 they get for it and just send it locally once?
Well, Larry, this is Mark Finn. It may be the local guy still gets the $500. I can't comment on that, but I get some treatment down at the UFC, and that in many ways is my primary oncologist. However, I go ahead and have a local oncologist with where I started off, and I continue to work with them. And that's where I get my Zytiga, my Xgeva, my hormone shots. I get my Zytiga prescription filled locally. So if your doctor's a Sloan Kettering, in any situation, they should be willing to work with your local oncologist. So you shouldn't have to travel back and forth just for that kind of treatment. Now, your regular checkups and so on, you have to have that discussion. If not, I would get a different team.
Doctor is not. Yeah, my doctor is not going to even see me. She's just going to follow up. She's going to have a telecall.
Well, just work. I think your local oncologist, you just have to find one, and I'm sure they're more than willing to work with you and help you out with that.
Okay.
Yeah, this works out well for me. This is Dennis in Korea. This works out good for me that I have both a local oncologist here in town in Tucson, who happens to be good friends with my primary doc up at Mayo Clinic in Phoenix. And so I get all my shots, my blood work, and so on, and prescriptions work done here locally. And I see Dr. Singh once a year for my annual surveillance checkup and see where I'm at. And so, Jerry, if you need information, I may have given it out before, but it's a Dr. Rafiath, and he's here in Tucson. He's with Arizona Blood and Cancer. You may want to see if you can get your shot. To me, it wouldn't make sense to go from where you are all the way up to Phoenix.
Yeah, I do. So. Dennis, I do get my shots with Dr. Killian. He's a urologist, kind of oncologist. He does do some trial work. He used to have 3 or 4 trials going. I don't know about now, but I'm not really worried about getting those shots there with him because I set that up with Dr. Singh. But my key is to get up to Dr. Singh because I haven't seen him in 6 months, and so I want to do the lab work and that. And quite honestly, I've got to talk to both of them because I haven't had any exams for 6 months.
Okay, so let me tell you what I'm doing, because that was what I was going to talk about, and it does involve Mayo and Dr. Singh. I have been reading everything the Mayo website, Mayo Clinic website locally, and what they're doing for cancer patients and so on, as well as looking at everything else I get my hands or eyes on. Alicia Morgan's video that she did, looking at her advice. Long story short, I have been scheduled for my annual exam next Monday, which would include the lab and scans, and then you with Dr. Singh. And I've made an executive decision based on everybody's input to postpone it. For me, I've been up there, there's everybody's wearing masks and so on and so forth. But their own advice is they're postponing all non-essential cancer screens, surveillance type work. If it's an urgent thing like Peter's and chemo, everybody's saying, don't let that go. You need to continue that. But for a lot of other things here, especially like just surveillance, postpone it. Then I'm scheduled to get my lab done, let's see, on the 28th here locally, which I will keep that because I don't take the risk of going there relative to the COVID-19 is anything like going up to the Mayo Clinic.
What about Lupron shots?
Yeah, I get that here locally. And you should stay. From what I understand, from my understanding of what the people have been putting out, and that's, I said Alicia Morgan's was one. Mayo Clinic has a lot on their website. The American Society of Clinical Oncology, ASCO, they did a video saying the same thing. If you're in treatments, you need to keep doing it. Especially, I mean, Lupron, if you've had a 30-day, 90-day Lupron, which is what I get, one of the options there is to maybe go for the 6-month instead of quarterly. So right. This thing's going to be with us for a while. And a lot of it depends, I think, on where you go, the size of the facility, how busy it is, crowded, so on and so forth, relative to the risk. And that's, for myself, I've just made this executive decision. So I sent the email yesterday telling them based on everything that they're saying and what I'm saying, they did say that they were going to be postponing these types of visits anyway, but they won't do it until like 3 days before your scheduled appointment. So I just wanted to get this off my mind and get it resolved as quickly as possible. So I just took the lead and sent the email out to Dr. Singh's office.
Yeah, that's what I tried to do too, but Dr. Singh's not getting back because we're with us. I talked to scheduling, and scheduling, like I said earlier, they don't even look at June until the last week of April.
Well, I think, guys, that, rather than getting into the nuts and bolts of each doctor, the first thing is that you need, all of you who are thinking about this, you need to get back to your doctors and ask them what the half-life of these drugs are. So if you've had, what length shot you last got, it might have been 90, it might have been 120, it might have even been 180, whatever the depot was, and whatever the type of LHRH it was, recite that, and then be sure to ask the doctor, how long can I wait, or when do you think this will wear off in my system? So you've got to drop these docs a note. Same thing with the Xgeva, which is what Jerry mentioned. Certainly with the Zometa, the half-life of the Zometa is very, very long. I would be surprised if the doctors had an issue with you skipping a Zometa shot. I don't know. Len, do you know what the half-life of denosumab is?
Well, I know that at least in the case of Dr. O, he treats his patients only once every 6 months with Xgeva. So it's got to have a pretty long half-life. So I wouldn't worry about that unless you're going well over the 6 months.
Right.
So Meta, I'm not sure about. I know it also, like you say, Rick, it does have a very long half-life. I don't know exactly how long, but yeah, I think a lot of docs also recommend pushing out. I mean, even under normal circumstances, not giving the Zometa quite as frequently as we have in the past. Like, Jake, how often do you get your Zometa?
I normally get it every 5 or 6 weeks. She wants me to do it every month, but I always get it every 5 or 6 weeks based on what you and Rick have told me before. So
Yeah.
that's why I canceled. I haven't been in since the 28th of February when I got my last Lupron shot, and I got a Zometa then. So I've canceled everything until June, which is my 4-month Lupron shot. I had no problem canceling the Zometas in between based on what we've discussed on this call before, because like we said, the half-life is good, and the doctor didn't have any problem with that.
Right.
My question is, what about the Lupron shot? Can you skip the Lupron?
So let's sort of stay a little focused here. So with the Xgeva, we're not really sure.
Right.
With the Zometa, there are trials that say that 3 months is as good as 6 weeks.
Right.
So, you can go once every 3 months on that, and there's trial evidence on that.
Well, I'm going to go 4.
So you certainly don't need it every month, and every 6 weeks is more than we would. If it were me, I wouldn't be getting it every 6 weeks. I'd be getting it less frequently. But
right. Yeah, we talked about that before.
With the Lupron shot, Carl dropped us all a note here and says that his Eligard and Xgeva shots have been delayed for 4 weeks, and it's not an issue. I remember he told us that a couple of weeks ago. It really depends on the depot, the length of shot that you got the last time. If you got a 30-day shot, like, for example, Russ was getting at the beginning, you obviously can't go another 30 days. But if you got a 90-day shot or a 120-day shot and you've been taking it for a while, and the longer you take it, the slower your testosterone returns, we know that, then you can certainly wait a little bit longer. So my suggestion to any of you that are having an issue is please write to your doctors and ask them how long they feel you can safely wait. Now, Jake's case is a little different to Jerry's in that Jerry's pretty much under control. Jake's at a point where he probably needs to switch treatments.
Right. Rick, I think we should address that because that's probably a bigger issue here. I mean, it's scary because what Jake is facing is moving from hormone sensitive to castrate resistance. And it might be in many of our futures, and it's indicative of complete change of treatment. And I know it's something we don't want to really talk about too much, but it's a big one. So, I mean, yes, you got to stay on Lupron, but that's the small part of it. The bigger part is how to address this change, which is significant.
Let me just, and I'll let you continue, but let me just say it's a lot more than castrate resistant. Jake is clearly castrate resistant. He's been castrate resistant for a long time. The problem is that the drug he's taking to control isn't controlling right now. I think that's really what you're saying rather than castrate resistant. And the question is, what's going to be done next? And as Jake says, if he doesn't know his PSA, then we can't even plan another step.
Right.
So, and the other thing is that Jake, you go to your doctor's office to get your tests, correct?
Correct. I do it all at the same time. Yep.
Right. So you're not going into a hospital per se.
Correct.
So I think if I were you, I wouldn't be deferring. I think if I were you, I'd be careful. I'd wear a mask. I'd wash my hands. I'd make sure that the people around me were all doing the same thing. And I would go in and I would get my test if it were me. I think it's a different situation to you walking into a big hospital. That's my opinion. I mean, you know, this isn't medical advice for any of us. It's our own risk aversion.
One other thing to find out about, Jake, might be, I don't know if you usually bring anyone with you when you go or not, but specifically Mayo says no visitors, patients only. There's very few exceptions where they'll allow an accompanying visitor to accompany you.
Right. Well, you know, I could go to LabCorp or or I could go to my doctor and get a blood test. But you know, doctors' offices and hospitals in particular are just notorious germ magnets anyway. And I'm just thinking, you know, the lesser exposure, the better. And that's why I canceled my March and April appointments and probably my May. Maybe I should go in and get one of the PSA tests there. I think you're right about that, Rick. I do agree with that. I'll skip this event. I don't think I have a problem with that.
I personally have been going in, and if I find it very, clinically safe, and I'm not that worried about the virus. If I get it, I get it. But I personally have been going in.
Okay.
Rick, just a quick question on Xgeva. You were talking about the half-life and that. I get a month's shot, but Dr. Killian said, you get a month's shot, but we'll do it to you for every 3 months. We'll give you that shot. I was a little concerned about the third month and whether I have any Xgeva in my system or not. And he didn't know the answer for that. So should I go to a 3-month Xgeva shot? I don't know. That's something I was going to try and bring up because I don't know the half-life of Xgeva.
Well, again, you've got to ask the doc. We don't know. Len, who's our expert on this, isn't too sure. I do know that there are some docs that are happy to give quarterly Xgeva shots. I think that's how Carl gets his. Other guys give it once a month. You know, these bone strengtheners have a really long half-life in your body and keep working for a long, long time. And sometimes they, if you've been on them for a real long time, they say to you, come off them for a couple of years and then go back on. So it's not like the Xgeva is not as critical to the progression of the prostate cancer as is the control of your testosterone, which is a much bigger issue.
Yeah.
So, I think that Xgeva, that there are a lot of men who don't get a bone strengthener. And if it were me, I would be getting a bone strengthener, but I bet you there are guys on this call right now that have bone metastasis who aren't getting a bone strengthener and should be. Well, I shouldn't say should be. That's if it were me, I would definitely be getting. So I wouldn't be so worried about the bone strengthener as I would about the testosterone. And Jake, from your standpoint, and I think, we have to take each person individually. In your case, I would probably want to go in, get my PSA tested. And frankly, if I was there, I would probably get a Lupron shot, even if I'm not quite ready for it. And so that way you don't have to worry. So
I don't know about that. I don't know. I get the 4-month shot. I don't know about getting it at the 2-month point. I don't know if that'd be a good idea.
You got to talk to your doc about it. And I don't know how that would work. It may just double up. So maybe you cannot.
Yeah.
But it's certainly a discussion I would want to have. Is there anything I can do right now that can extend my Lupron shot so I don't have to come back at the same time? I would be concerned about keeping a close-ish eye on your PSA.
Right. Well,
and talking to her about, if she says, well, we've got to do something, then you're going to be back in there anyway. Then you've got the decision that Peter's talking about. Well, what's next? And how am I going to trade that off with respect to the COVID? Peter, that brings us to your topic.
Right. Chemo is next for me, and that's right. Exactly.
Do you want to talk about that quickly, and then we'll circle back to Mark Finn, and then we can pick up this discussion momentarily. And we have a couple of guys that have arrived, so we want to just touch base with them. We recognize you're here, and thank you, but we're trying sort of tying up some ends here with respect to COVID and how to manage your treatment. Peter.
Peter dropped off for a second, Rick. He'll be back, I'm sure.
Yeah. Well, he was with us momentarily. I think he just closed maybe he's having connection issues there. All right, well, I'll tell you what, why don't we just check in with the guys that have arrived since, and we'll go to Mark Finn, and then we'll pick up this discussion in about 15 minutes or so when
Rick, I'm gonna need to drop off and come right back on because this happened to me last week. I lost all my controls. I got a notification that I have a message, but I can't access the chat box or anything else. It's all disappeared. So
okay. All right.
I'll be right back.
Okay.
Bye.
So let me just check in. Carl Forman, if we have the time, maybe you and Paul could tell us a little bit as to whether Richard Wassersug's seminar was helpful.
Yes, it was helpful. It just gave me a refresher about ADT and side effects.
Okay. So is there anything else that you wanted to talk about today?
No.
Okay. So that'll be a question mark. We can always do that another time as well. John Hall, anything that you'd like to talk about today?
No, I'm fine. I'm enjoying listening in. I don't have anything new.
Okay. David Muslin, anything for you, sir?
No updates, Rick. Thank you very much.
Okay. And I've got 2 DMs on here. I don't know who the other DM is.
I'm the better one, I can tell you that.
I don't know who the other DM is. Anybody got any ideas who the other DM is? We got a David Muslin.
It's Dennis McGuire.
Yeah,
Oh, that's Dennis McGuire. Okay. Oh, you guys are fooling me here. And then Gary Alexander, welcome. Have you been with us before?
I have not. Steve Rockline's a good friend of mine, and he sent me an email the other day along with some information about Ancan, and so I'm starting to get a little better acclimated to, virtual meeting wise, and I thought I would check you guys out and see what I can learn.
Okay. Well,
welcome. Thank you.
We like to try and accord new guys some time, and I'm just going to sort of look and see if we can carve out about 15 minutes for you in the next hour and 10 minutes. So if not, then hopefully you'll come back and we'll open the meeting with you if we cannot get to you today.
That's
fine. Okay. Yeah.
That's okay.
Okay. So Peter's back. Hello, Peter. We are going to come back to you and pick up the discussion that was going on just before about deferring treatments in the era of COVID and choice of treatments in the era of COVID. But first of all, I want to go to Mark Finn, so Mark can give us a quick update on his situation? Because he mentioned that he has to sort of drop off in about 15 minutes. So Mark, why don't you tell us what's going on with you?
Well, a couple things. First of all, to add to the discussion about Zytiga or Xgeva, excuse me, I've extended my Xgeva shots with talking to my physician to 6 to 8 weeks, so I'm not particularly concerned about that. And I don't know, I'd have to have another discussion if I was going to make it quarterly. That I haven't really, because definitely it's a bone strengthener, but there's also some kind of ad hoc information, particularly among urologists and oncologists, that it does seem to provide some protection of the bones from prostate cancer in the bone. I'm not sure if that's been run in a really scientific study. So my situation is I just continue to do well. I'm castrate resistant metastatic stage 4. Right now I have really no complaints. I'm on Zytiga. I'm on a low dose option. My PSA came down from like 4 down to around 2, and it's sort of hanging out around there right now. So I wish it was 0, but compared to some of the other options, I'm very pleased of where it's at. And so we'll just sort of see. I think right now I'm not as concerned with a lot of the monitoring appointments as far as PSAs and so on, because really I don't expect that my treatment is going to change much until such time as Zytiga begins to fail miserably. And then at that point, then we might go to some other option. The other thing is I think you do have a period of, I don't know, who knows what it is, 2 to 4 weeks flexibility when you get your Lupron, or in my case, I take Trelstar. I think you have some opportunity, some flexibility there, but unless your doctor really supported it, I'd be uncomfortable going much longer than that, because I believe your titer does start to decrease, and so you do want to think about getting that shot. But again, I go for 6-week shots, and it's just so I don't have to go in and out all the time. So that's sort of my situation. I also, I'm not sure when I last talked to you, Rick, I did have some SBRT that seemed to do a nice job with the one of my major lesions in my spine. At the same time, there are some additional lesions, and whether those are really cancerous or others, we'll have to wait and see when it makes sense to do a PET scan in the future. But right now, even if they were, I'm not sure if they were big enough that you go after them again with SBRT. So that's kind of where I'm at.
How are you managing on the Zytiga and the prednisone?
Right now I'm taking the low dose Zytiga and prednisone. So instead of the 1,000 milligrams a day, I'm taking 250 with 5 milligrams of prednisone with a low fat breakfast. And that seems, actually the fatigue issue has not been very dramatic in my case. I have a feeling if I was more on 1,000 milligrams a day, that maybe my situation would be different. But right now, I seem to be at the low dose, being able to manage the side effects of Zytiga pretty well.
That's very interesting. And is you're still with Dr. Stadler, right?
Yep.
Yeah. This is probably a discussion for any other of you guys who are on Zytiga now. Any of you want to ask Mark any questions about being on the low dose with food versus what most of you are on, which is the high dose before food? Any questions on that from anybody?
Yeah, Mark, were you ever on the full dose of Zytiga before you switched?
No, I was on when my PSA went up to around 4. It was decided that that I should start with something else besides just my Trelstar. And so when talking to Stadler, and they did a study, I believe it was in 16 or 18, I think it's 18. And the study showed that when you, in the group that they had, and it wasn't an extensive group, but my recollection, it was like 80 to 100 people in it. And that they found that the actual progression of disease, both from, I might not overstate, I think I've sent Rick the article before, so he has it. if anybody's interested. But it basically showed that the progression of disease and the increase in PSA was really no different between a low dose group and a high dose group. And so the only difference between the two groups in this, I think fairly call a limited study, was that the people who were in the high dose group had a much higher blood titer of Zytiga. Well, that makes sense. They were taking 4 times as much. So far, particularly my going down, I think that I know that Stadler, I've talked to him with my PSA not going down as dramatically as like, should we go to a high dose? He is standing by the study that they did. He thinks that it shows that that there's no advantage for me, particularly going to the 1,000 milligram dose. That's something I have to think about. If my PSA, before I went on to some other kind of thing, I guess I could think maybe taking the hammer to it and going to 1,000. But right now I'm not inclined to do that.
Well, my recollection of that study, I'm familiar with the study, but my recollection was that if you take Zytiga with a fatty meal, it gets absorbed something like 4 or 5 times greater than if you take it on an empty stomach. So basically, the amount of drug that enters your system is the same. So you wouldn't really expect any difference in fatigue or blood levels, because the whole point of the study was to show that you can achieve the required blood level of Zytiga if you just add some fat and have it with a meal.
Well, actually, that might be true of some study, but this study was with a low-fat meal. And although
if you had a high-fat meal, then it would be 10 times the absorption rate.
Yeah. Okay. So they do it with a low-fat meal, and unfortunately, Stadler's pretty boring because what I haven't really had a chance to sit to him in the same room and talk to him about is whether, he keeps saying every time I say, what's a low-fat meal? I mean, I can figure that out, but do they have a diet to recommend with it? He says, well, take oatmeal.
There's no fat in oatmeal. But anyway, what I had heard is that 2 tablespoons, the equivalent of 2 tablespoons of peanut butter, almond butter, that's considered a low-fat meal.
Yeah. Well, I've been staying with just the oatmeal. One of my thoughts is the next time I get together with him is whether, they ad hoc and that they think that the oatmeal was what people ate, and so therefore that's what their suggestion, or he's just being lazy, because there's lots of different things I can eat for breakfast which are relatively nutritious but have no fat. So
how much prednisone are you taking, Mark?
What?
How much
prednisone? 5 milligrams in the morning with my meal. 5 milligrams.
Okay.
Yeah.
But Mark, take a look at your oatmeal. It'll probably say 0 fat. There's no fat in oatmeal. It's just carbohydrate.
No, I don't. I have a no fat breakfast. He says low, and I have no, because I have no fat milk. I have oatmeal. I have a little bit of blueberries, and I throw in some brown sugar. That's my breakfast. And so I'm really having no fat. And then there's really no information on it, but I usually then wait 1 to 2 hours before, if I'm hungry, I eat anything else. And then if I eat then I'm more than, I can go and have a fatty meal if I so choose.
Well, those studies, though, like Len pointed out, those studies talk about low fat. They don't talk about no fat. They do talk about low fat. Maybe you need to add some to help with the absorption.
It could be. That's a very valid question.
Mm-hmm. So I've put a link in the chat window to a phase 2 study. We've been talking about Abiraterone with food for years, probably 5 years. Let me just mute. We'll identify caller 3 in a minute. We need to mute them just for the time being. Thank you. We know this works. The usual issue with the men who go on Zytiga is that they're nervous to try it. And so I think the guys have a good point. You do need some fat to probably increase the the level of absorption, and it wouldn't surprise me if you did that, that you might even see a drop in your PSA.
That's a good point.
And that isn't even something you have to talk to your doctor about, because the protocol in the trial was a low fat. Now, how much low fat, that gets above my pay grade, I don't know. But,
Well,
you know, adding a little bit of fat, you know, a knob of butter into the oatmeal, or, you know, some milk, some 2% into the oatmeal, something like that. And you can play around with it and you'll see. You know, yeah, I mean, obviously you're going to have to do it month by month, because you'll test your PSA month by month. But you could play around with it and see if you get, and definitely let us know. But I just think that this whole discussion about the low-fat Abby, the reduced Abiraterone dose with food, should be very interesting to all the guys who are on Abiraterone on this call and who are going to listen to the recording later. And what it sounds like to me, looking at Mark's numbers, is that it is controlling Mark's disease, maybe not quite as well as he would hope, and maybe we've touched on why, but it seems to work when you're taking a third or a quarter of the dose in Mark's case.
Well, Mark, what was the your initial treatment and Gleason score? Status of Mets.
I'm a metastatic stage 4 Gleason 9. Never had a high PSA. My PSA was only like 6 when I had surgery. Never was.
Prostatectomy.
Yeah, I did.
Okay.
So I do think back to Rick's. Excuse me.
Follow up radiation? No, nothing.
No, I had clean margins.
Okay. You don't know how many Mets did you have? Bone Mets?
Of what? Of the radiation I had?
Bone metastasis, how many?
I think right now it's fair to say I've had 2 major ones, but actually one of them has kind of shrunk, the one on my pubic bone. I right now have, I had one in my T6, what looks like the SBRT took care of that. And then I have maybe, you know, a couple of more. I have 2 more lesions on my spine, but, you know, we really, I'm not convinced that, I mean, they probably are cancer because of my situation, but we won't know for sure if they're cancer until such time as I get another more detailed bone scan of some sort. Because I mean, I've had situations before where, you know, they've said, oh, you have another lesion. It's on, and I say, I know where it is. They say, well, how do you know that? And I said, it's on my rib. I fell down and broke a rib, and that's what you're seeing. They said, oh, yeah, that's right. So, you know, and any sort of unless they get a real bone scan or PET scan, they don't necessarily know for sure where it's at. I will say that the one thing is, for people who are struggling, you know, quality of life wise with Zytiga, then having a low dose option, I'm not selling it, but it's something you should discuss with your doctor. The other interesting thing I will say real quickly is, you know, I get my Zytiga through Express Scripts, and interestingly enough, the only thing Express Scripts has is that if you get Zytiga, you get 1,000 milligrams a day, and you get 10 milligrams twice a day, you know, 5 milligrams twice a day in prednisone. So when I renew my script, I get sent, you know, like a bucket full of Zytiga. I'm not even using, I mean, over a period of time I use it, but they won't send me a low dose option script. They'll only send you the high dose.
Yeah.
Was there another question somebody had?
Well, one thing I want to mention in Mark's case, that he was diagnosed metastatic and did opt for an RP, which should be of interest to Carl Forman, and he was a Gleason 4+5.
Yeah.
So so that sort of fills in some of the background. Anyway, I don't want to belabor this much more. I think it's been a really interesting and worthwhile discussion. We love when we see your face, Mark.
I'll try to get on more often. It's just, you know, it's at 5 o'clock in Chicago, and that interferes with wine time. So it's a matter of having to consider my priorities, you know, so.
Well, but our other meeting, our Monday meetings are at 7 o'clock Chicago. That's even bigger wine time. So, but thank you very much, and stay on as long as you like, disappear when you need to. And I think that, you know, we've talked about a really interesting issue to a lot of guys on here, and hopefully giving them some food for thought. And we hope that you'll give us some feedback from what we talked about today.
Well, I would say if anybody, is interested to discuss this further, you can get all my information through Rick, and I'd be glad to talk to anybody who would be interested in, discussing this more. Particularly, I think I do know there's a few people I know in my other local network who really struggle with Zytiga. I mean, they sometimes find it hard to get out of bed. So I think unless if it's working, that's great. If it's really eroding your quality of life, then I think it's something to consider.
Okay, yeah, I mean that. Use Zytiga, guys, as you heard. Fatigue is not taking a great toll on Mark's existence. I wonder if that has anything to do with a lower dose. Just asking, don't know. So, all right, let's just keep moving on. We have we'll unmute the caller. We have another caller. I just saw you. Where are you? Can't find you here. Caller 3. So, who just arrived on the telephone?
Peter.
Oh, Peter arrived on the telephone. Okay. Peter, I'm glad you arrived on the telephone because we want to pick up where we left off with you. Namely,
can you hear me?
We can.
Yes.
Can you hear me?
Yes,
Okay.
clearly.
Yeah, I was having internet problems here, so I've gone to the phone and the.
Okay. Yeah, we hear you well. So Peter, you raised this issue of COVID treatment. You raised it in the context of Jake and needing to switch treatment. So tell us a little bit about what's on your mind, what you'd like to share on that.
Okay. Before I do that, I just want to let people know that I lost my buddy Jim St.James this past Saturday morning. Some of you remember he's been on the phone a number of times.
Yeah, I apologize for
not recent
with that.
Yeah, he had a very rapid transition from about 2.5 years from diagnosis to passing away. So it was a tough one, and very, very rapid movement. He had the germline BRCA mutation, and it just progressed very, very fast. And maybe he could have done some other treatment options and so forth, but that's besides the point. It just got out of control very, very quickly. So
Peter,
I want to bring that up. Yeah.
Was that photograph of him holding the moon? Was that actually the day before he died?
I think 2 or 3 days, about 3 days before he died. Yeah, he was in hospice.
So he must have been doing okay until the very end, which is great to hear.
He was a very bright, energetic guy. So was he doing okay? He put up a great fight. I mean, he was a wonderful friend and compatriot, but he was hurting pretty bad. So the last couple of weeks he was at hospice. A week and a half.
Peter, what treatments did he actually receive?
He did Zytiga. He early on he did a laser ablation with Dr. Sperling down in Florida, but it was a metastatic spot, and it just spread really quick. And the next time he had a scan, a PSMA scan, it was all over his body. And then he did chemo with docetaxel, but it didn't knock it down. His PSA was jumping like 1,000 points a month. It went to his liver, and he just he was suffering pretty bad.
How early on did he learn that he had BRCA2? germline.
Pretty early on.
So why didn't he opt for olaparib?
It gets very complicated. He had both an oncologist here, and because he did a scan at UCSF, he had a genitourinary medical oncologist at UCSF, but she wasn't really responsive. She didn't push. She was, saying, well, Zytiga doesn't work, try Erlita. I mean, she just, and then there was a communication problem between the two oncologists, and it just progressed too fast. Anyway, I don't want to get into analyzing it, what could have and should have and this and that. It was just sad. Okay.
I'm sorry.
The reason, just let me get this in, Jake. The reason I'm asking is because just recently we've had two guys come on the call talking about, oh, what's the difference? I'm not going to have any treatments. It doesn't matter. I think this is a perfect example of how we can see it does matter quite a bit, because Carl's doing fantastic on a PARP inhibitor. Professor Bill did very well on a PARP inhibitor. Now your friend didn't, and he died pretty quickly. So it does make a difference. Sorry about that, Rick.
I agree, but I mean, I tried my best. I tried to intercede. I tried to make suggestions. I tried to get him. I tried to somehow get this oncologist at UCSF to step up to the plate, but she was constantly on vacation. It just the dots just didn't connect. I mean, I could beat myself up and say I failed. I know I did.
Let me intercede here. This isn't about you, please. You couldn't have done any more than you did. And don't internalize this, or don't take this conversation as being any reflection on you. You did as much was humanly possible. And we're not, this is no criticism of you. What you had was a strange situation. I think Halabono was interested, but there were communication problems. You had a difficult oncologist in Hawaii, on Maui, Hawaii, who really had no experience treating prostate cancer men with PARP inhibitors and was reluctant to go there, and he wasn't pushing for it. And then when she was ready, Jim didn't want to go to another treatment. And there was it absolutely had nothing to do with you. I mean, I had a couple of discussions with Jim. So all I think we're saying here, it's absolutely no reflection on your advocacy. You couldn't have done more than you did. And we really are grateful for what you did for Jim. Jim knew what was going on. Jim was, in his own way, a strange guy. He wasn't that keen on any type of treatment. He really would have preferred to, he was really, he wanted to go the natural way. And there are other people on this call, many of you, who were very aggressive in your treatment. Jim was not his best advocate. He never really advocated for himself at all. Peter advocated for him with his hands tied behind his back, with Peter's hands tied behind his back. And so I just want to make it very, very clear, this has nothing to do with you. And I think that, as Len rightly says, if there are treatment paths that are available to you and you're feeling good at the time, we encourage you all to try them and not to sit back, because some of them may work, as Carl will tell you. And you are your best advocate. We'll advocate for you. We'll help you any place we can. Len is doing that now admirably for Richard Foodie, who's in a very, very difficult situation with very weird disease. And, there you've got a situation where Foodie is just not his best advocate because of his nature. Not that he doesn't want to be, not that he doesn't want to do more treatments. Sometimes people have difficulty advocating for themselves. Foodie knows it, and he's asked Len to help, and Len's doing a sterling job. That's what we're here for. That's what we'll do for you. But if you can do it for yourself, even better. So let's just leave the Jim St.James conversation. I apologize to you, Peter, for not starting and paying tribute to Jim. We do have that photograph up on our in memoriam. It's a wonderful photograph. Hard to believe that it was taken so close to his leaving us. And I suggest you all take a look at our in memoriam page, and you scroll down to the very bottom, and you'll see this beautiful picture of Jim holding up the moon. Peter, let's get back to your issue.
Okay, here I am advocating for myself. So some of you heard me last night on my call. So I'm in this odd place here, out in the middle of the Pacific. I've done 2 chemotherapy treatments already for last week. Last Thursday, and I got a tip early in the morning that we had an outbreak in the hospital, so I canceled it. And in the infusion arm of the cancer center closed down anyway. Just quick background: we have one hospital here on Maui, and the state used to run it, but the state kind of gave up on it a couple of years ago and went out to bid, and Kaiser took over the management of it. It's not a Kaiser hospital, but Kaiser runs the management of it. And accurate information in the news today, it said they had an outbreak at the hospital with 34 cases of COVID-19. Then it went on to say that included 2 nurses and 1 patient. It didn't say what the other 31 people were. It just, whether they were janitors or receptionists. They don't give you information. You're not getting stuff. So the hospital called me a couple of days ago or last week and said, I'm rescheduled for this coming Friday. I talked to an oncology nurse on Oahu that works with my local oncologist here, and we kind of went over things. And I sent an email last night to Dr. Turner, my medic in California, with prostate oncology specialist, and told them what I was thinking. That that weighing everything and looking at the lack of information I'm getting and clear direction, I feel more comfortable if I skip this whole cycle and put it off till the 30th of April, and did my number 3 treatment then instead of my regular scheduled number 4 treatment. And Dr. Turner's, his reply briefly was, it's not the most ideal thing, but considering the circumstances, he feels it's probably the way to go. Because you get into blood tests, rescheduling blood tests. I mean, it was kind of getting crazy, and I just don't trust what's going on here. And for my own health and sanity and safety, I feel that's. I mean, it's a crapshoot. I mean, 4 months from now, we're going to have a meeting that said Peter died because he skipped a session of chemo. I don't know. It's a crapshoot, but I feel strongly that advocating for myself, this is the way I've got to go, because it's just really weird here. I mean, you guys have the option, many of you, of getting in the car and driving to another hospital. I don't. So it's if I got in, I thought of everything I could. If I got in a plane and flew to Oahu, a 20-minute flight, but then I got to get in a cab or something with God knows how many people were in the cab before me, or the driver or whatever. So anyway, as you know, chemo puts you in an extraordinary vulnerable position, and I just want to be real cautious. So that's the update.
Thank you. I mean, really, you're between a rock and a hard place here, and for those of you who are wondering, because Peter and I have talked offline, Peter's Maui oncologist is actually not on Maui, he's on Oahu, and he pays a weekly or fortnightly visit to Maui. So it isn't like there is a doctor's office set up to administer chemotherapy on Maui outside of the hospital. That's why Peter's talking about having to jump in a plane to go over to Oahu. You know, it's all risk, risk, risk. And I think only you as an individual can make the determination. But I do think that, especially in Peter, in your case, Dr. Turner's input is critical. And if, even though it's not ideal, if Turner says you can skip one, skip it. But my bigger concern is what happens if you skip this one and the next one? And that's what I'm really concerned about. I think if you miss one, that's fine. But what happens if you miss two? And maybe we should say, well, we'll cross that bridge when we come to it. But with this damn virus, I don't see it resolving too soon. And if it were me, I'd be having that discussion with Turner right now, because it may change the treatment. He may say, let's cut the chemo, let's start the PARP inhibitor. Peter has a somatic BRCA mutation. So that's really, I think if it were me, that's what I'd be doing. Because there's such a high likelihood that come the next 3 weeks from now, you'll be in the same situation again.
Yeah, it could be, but I mean, I keep in pretty close contact with Dr. Turner. I mean, fortunately, I have a doctor that, you know, responds to me on email within hours or the next morning or whatever. I mean, I don't have a hard time reaching him, and he knows all the factors. You know, I update him with everything without overburdening him. So, you know, for sure we will have that discussion as we get closer. If they don't resolve things at the hospital in the next week, I mean, I'm not the only one facing this. There's other people doing treatment too, and they can't get away with just closing down the cancer arm of the hospital when it's the only facility there is on the island. So, I've got to bank on that, but I'm sure if I needed to start a PARP inhibitor, I could do it pretty quick. So, so that's where I'm playing it. I mean, I don't want to jump the gun, but it's kind of where I am.
Peter, Dennis Correa here. Just another thought. The facility that you go to, that's been where the outbreak is, maybe you could find out more info about exactly who, where these people work there. How separate is the infusion area from the rest of the hospital? Is there a direct entrance so you don't have to traipse through other areas of the hospital? And like you said, you could, you know, almost wrap yourself up, get your N95 mask and your gloves and so on, and maybe you could still do it.
Yeah, I check into that. I mean, I'm constantly on trying to get information and so forth, but the Kaiser management is not very forthcoming yet. Yes, it is out of the emergency room. It does have its own entrance, but it is one large room. I don't know, you know, infusion centers have that, you know, numerous reclining chairs separated by curtains. I mean, yes, you're more than 6 feet apart, but you've got the same nurse or several nurses going around to the different people. It's not the most ideal situation. As Rick will tell you, yeah, I was kind of fantasizing yesterday that I could do drive-through chemo. I could do this in my car, because all it needs really is an extension cord or a generator, because it's just this little pump that pumps the drips from these bags hanging on a tree into my port. So I mean, I could sit in the parking lot and do this with a with a urine with a jar to pee in, and 4 hours later I drive away. So I mean, I'm thinking, like any kind of guy, I'm thinking of alternatives as fast as I can.
What about a home health care service that might possibly be able to do it? Is that a possibility?
I don't know. You pretty much need a trained chemo nurse. I don't know if home health people can do kidney stuff, dialysis, and so forth. I don't know if home health nurses can do chemotherapy. It's a good question. I could check into it.
Well, Peter, don't they do labs before they do the chemo anyway? You have to have like blood work done before they approve you.
Yes, I have a local lab that I go to a few miles up the road, and they're still open and they're fine. I'm the only one in.
Gotcha.
Phlebotomist, and I feel comfortable with that.
I think we've sort of batted this around enough and a lot earlier on now.
Can I ask Peter one question? Are you still on darolutamide, Peter?
I can't hear you.
Are you still on darolutamide, Peter? Are you still on darolutamide?
Yes, I'm still on darolutamide. It's kind of working, not the best. It's Monday, a week ago Monday, it was 0.7, it was 0.68 before that, it was 0.59 before that. So it's kind of hovering around the mid-range there.
Okay, well, let's move on. I mean, I don't know that there's too many people that can advocate better for themselves than Peter. If there is a solution, I think Peter will come up with it, but my 2 cents for what they're worth, Peter, is don't wait too long. If you do miss this one, don't wait too long, get too close to the next one, because, start thinking about what might happen, and you may have to make a decision choice. And, maybe you'll go to the PARP inhibitor and then you'll return to the chemo later. But
right.
I can safely say that I don't think there's any fear that you will be not with us 4 months from now. I just want to say that that is the last thing that, God forbid, unless of course you were to, God forbid, contract COVID-19, and but the cancer certainly ain't gonna take you.
Peter will probably outlive all of us, the way he takes care of himself.
I know. All right, so we have about half an hour left. We've got 3 people at least to visit with. If we get through them, we've got a couple of people in reserve. So let's go to the Len and Bill conversation about radiation proctitis, first of all. And Len, why don't you kick it off and bring Bill in and myself in as you need us.
Okay, I thought we were going to be the ones in reserve. This we could talk about at any time. Doesn't need to be tonight. Is there anyone else who really needs to?
All right. Well, let me do it this way then. Let's go to Dennis McGuire and then Peter Monaco, and then we'll come back to you.
Good.
Okay, Dennis.
Yeah.
Hey everyone. You got promoted in the batting order there, Dennis.
Pardon?
You got promoted in the batting order.
Yeah. Let's see if I can hit one out of the park. So
okay.
Just a quick update. I started radiation last week. I've had 3 sessions, and I have 2 more this week, Wednesday and Friday. I'm fortunate that the radiation center at the University of Wisconsin is isolated from the rest of the hospital. So I really only come in contact with the two radiation technicians who are in, like hazmat suits, full mask, face shields, gloves, no exposed skin, nothing. I did learn a few things as I went through this process. I was expecting that I'd have scans at the outset and then show up for the radiation and just get radiated, but it's been a little different. They have me on an MRI machine, so I get scanned before every treatment, and then it's dynamically scanning as they give the radiation, so that if something moves during the radiation treatment, it stops. So that was a lesson learned for me as I've gone through this process.
How long is each session? I guess it depends if you move too much or not, because they have to stop and restart, roughly.
Yeah, no, they haven't had to stop and restart, but I'm in the machine 60 to 75 minutes each time.
Wow.
And that's radiating 3 areas: the prostate, a lymph node, and a spot on my I guess what it's called ischiac bone.
Wow. Well, for those of us who have done IMRT, of course, that's very different because we're used to 10, 15-minute sessions. Now, so you're in, I'm just trying to figure this out. You're being constantly monitored under the MRI, but you're getting the SBRT. So the SBRT is being administered in the tube whilst you're in a tube? Oh, wow.
Yeah, I'm in a tube and getting the SBRT, and the machine itself is called Meridian, MRIDIAN, and it's called ViewRay technology with a linear accelerator.
Mm-hmm.
I think the technology's been FDA approved for about 2 years.
Has anybody else had, I mean, some of you guys, I think, have had spot radiation using SBRT. Has anybody else had this system when they're in an MRI tube? So let me rephrase. Who's had spot radiation? No one?
Well, I had proton beam radiation for follow-up, and they had a constant CT scan going, making sure that everything was going to the right place. And I was in for about 45 minutes to an hour for 2 different spots. But it wasn't an MRI, but it was pretty elaborate.
But that
wasn't a tube.
That was not a tube. That was an arc over you, correct?
Right. Correct. Yeah.
Okay. How are you feeling? That's the $64,000 question, Dennis.
Yeah, the first 2 times that I had it, I actually got very fatigued later in the day. I've had the sessions early morning, and by like late afternoon, I was very fatigued and just took a nap. Listened to my body and just laid down and took a nap. A little bit of loss of appetite, but that's it.
Okay. Have you been walking? I mean, I think it's so important to, like, you know, if you can, 20 minutes, 30 minutes to do a walk after you've done your session.
That I have not done. I have been on, in between sessions, I'm keeping to my regular workout schedule. So that has not impaired me at all, but that's good. Maybe get up and walk around right away.
Yeah, I mean, you know, when you get done, if you can, before you feel too tired, get out and take a 20, 30-minute walk. I think it'll help you. Try it. Let's see. We'll talk to you and find out.
Hey, Dennis,
All right,
this is Len. How many sessions do you have total? 5?
5.
And you've already had 2.
No, I've had 3, so I have 2 more
3.
left.
Oh, okay.
Yeah,
And
so Wednesday, Friday.
Rick was talking about spot radiation, but if I recall, weren't you having total prostate gland ablation plus the spot radiation to the lymph node?
I'm sorry. They're doing the prostate. I'm sorry, I kind of misspoke. They are doing full prostate plus the lymph node and the left hip.
Right. Okay. Good luck.
Yeah.
Thanks.
Yeah. But you know, the thing is that because they're going up this pelvic girdle, I think that's probably one of the reasons why you're feeling fatigued. But we hope it's going to be successful, Dennis, and we just want to encourage you to, you know, each day to just do a little bit, do what you can. You know, 15 minutes, 20 minutes. If you're feeling good, go to 30 minutes. Don't push it, but it may make a difference for you. Is there anyone else who, go ahead.
The other thing is, I did ask the radiologist and my oncologist when they would expect to do scans again, and they said 2 to 3 months. They don't do scans right away.
Mm-hmm.
So that's their protocol. I don't know if anyone feels differently, if people have done scans sooner than that.
I think that's about normal from what I know. And anyone else have any input on how soon they've been scanned after they've finished this type of radiation?
I don't even believe I was scanned. They waited 3 months to just do a PSA.
Right.
And the PSA was 0.1, so I guess they felt it's too low to scan.
Well, I pray for that.
What was, speaking of which, I should make a note here. What was your PSA right before you started the SBRT?
It was 14.5.
Okay. Got it. Okay. All right. Anyone else have any questions for Dennis about this treatment?
Yeah, Dennis, do you have any urinary or intestinal issues yet?
Urinary, I would say the day after I have a slower stream when I urinate, but it seems to get better. That seems to be temporary.
Good. I hope it stays clear. You're getting a lot of radiation there. Yeah.
Are they making you fill your bladder or not with this type of treatment?
Yep, comfortably full bladder.
Okay. Okay.
And empty rectum. So I go through that whole process of.
Yeah, you got to go through that. Yeah, and we know. Yuck. Every time. You know, fortunately, I don't think I did not have to do that before each IMRT session. So, okay, well, hopefully you'll fly through this. We'll get that old PSA down and we'll go from there bit by bit. And I'm glad that you're comfortable, you're staying safe, you're masked, and I'm assuming you go in there with your mask and your revolvers, your six gun revolvers on your hips every time, right?
Yeah, and they do take your temperature before you walk in the building.
Okay, that's good.
Yeah,
that's good. That's good. That's good. That's good. All right. Well, let's move on to Peter Monaco.
I had to unmute my microphone. So, you know, I'm on the generic form of Fosamax. And I was wondering if anybody has been on these bone density medications, and what, if any, side effects did anybody experience? That's all. That's my question.
Okay. So, who has been taking Zometa or something a little weaker than Zometa, like the Actonel? I think it's Actonel that you're on, Peter, which you don't have to take daily. Is it once a week you get it?
It's weekly. Yeah. Weekly, and it's called, I can tell you in a sec. It's called alendronate sodium, alendronate sodium,
Right.
70 milligrams, and I think it's a Fosamax generic.
Right. If I'm not mistaken, the trade name is Actonel, but Len will correct me on that for sure.
It's Fosamax.
Oh, it's Fosamax?
Yeah, Fosamax.
I thought, Len, that the longer version of Fosamax was called Actonel, the one you take less often.
That's possible. I'm not familiar with that.
Yeah, I think so. I think the one you take less frequently is called Actonel. It's kind of like Prolia and Xgeva, you know?
Oh, I see. Yeah.
It's the same drug, but they just have a different market name for it. Look up Actonel and you'll tell us. But the question really is side effects. And well, Jake's been on Zometa for a long time, which is zoledronic acid. So maybe it's not exactly the same as Fosamax. I thought it was, but it may not be.
Yeah, Rick, I just looked it up. Actonel is risedronate, risedronate. So they're both bisphosphonates, but they're slightly different.
Different, yeah. Well, Jake's been on a bisphosphonate. I was on a very, very low dose of bisphosphonate that I got annually. Who has any input about bisphosphonate side effects?
Peter, do you take yours as a pill?
Yeah, it's a pill. I take it once a week. You know, you got to take it on an empty stomach, first thing in the morning, and you can't lie down for about 30 minutes. You know, they say to sit up. and drink it down with water and nothing else.
Huh. Yeah, I can't really answer that myself. I get an infusion, and I will tell you that for a day or two after I get my infusion, I feel like I've been hit by a truck.
Oh,
Lupron doesn't bother me at all. The Zometa, I do. I feel like I kind of have the flu for a day or two. So but you're taking a pill, so that's probably totally different.
yeah, yeah. I mean, it's no big deal. I'm just curious. They say one of the side effects is something called GERD.
Right.
Like acid reflux or something. Is that right?
Yep. It is. That's why you can't lie down after it. I was just going to mention that to you afterwards. I remembered that. That's why when you take the Fosamax or the Actonel or whatever you're taking, you have to take it the way you're taking it.
Mm-hmm.
Anyone? Is there anyone? Have you been experiencing any issues?
Well, I was. I don't know for sure. It's a funny thing. I actually spoke to Jake earlier this evening. I think it gives you possibly through the GERD, if it's causing acid reflux in any way, it affects your throat, your voice, and so I don't know. I actually had a slight tickle in my throat for a couple of weeks, and I was thinking I had the coronavirus. So I had a video call with my doctor, and we went over my symptoms, and he said no, it wasn't that. He said it was likely allergies. So I started taking Benadryl, and the symptoms went away pretty much. But then I was thinking, when I took my weekly dose of the Fosamax yesterday, I was looking at the box and the slip of paper inside the box, and I'm looking at all the possible side effects, and I saw GERD. And I said, doesn't that cause acid reflux, and doesn't that affect your throat as well? So just, coincidentally that these things happen simultaneously, but I had a week of high anxiety until I finally decided to call my doctor and say, do I have coronavirus? I have a tickle in my throat for a couple of weeks and no fever or no other symptoms. And, we talked at length, and he said, no, we went over the timeline when I thought I might have been exposed. And he said, no, the timeline didn't add up. It didn't jive. He said, try taking an antihistamine, which I did, and it did help. But then I wonder if there's another possible cause for this, and that's what made me think, and that's why I had the question. So it's no big deal. If nobody knows, it's all right. I was just curious.
Len, if you look in the chat window, Len you probably know this anyway because you've probably done your own research. But Len has put in a bunch of the side effects that occur from Fosamax. But, I do think it's a little different. Most of us have gotten bisphosphonates in form of an infusion, and I have a feeling that is a little different. So.
Yeah, it sounds a little different, but I'm just reading what Len put in there. And, if it causes esophageal issues, it could create a problem here, obviously. Sure. So, but the bottom line is I don't have COVID-19, so I'm very relieved about that.
We are very, very, very pleased to hear that.
Yeah.
So believe me. And I also want to publicly on here thank you for helping us out with the downloads and the uploads, Peter. It's huge.
It's my pleasure.
So
I'm glad
grateful.
You're very welcome. I'm glad to help.
We are really, really grateful. Thank you. Thank you so much.
No problem.
Okay, well, we have 10 minutes left, and I'm going to let Len decide whether we want to talk about radiation proctitis tonight or whether we should go over to Gary and hear a little bit about Gary.
Yeah, let's go to Gary. Like I said, we could talk about proctitis anytime.
Okay, well, we will talk about it because Bill and I are a little too familiar with the issue, and Len, keep it in your quill and pull out that arrow, all being well, next week, and we'll handle it next week.
What about Carl? Did he want to talk tonight?
No, Carl and Ulfrida were only going to talk about Richard Wasser's seminar. So that's one that can wait as well. That's not that urgent.
Okay.
So Gary, why don't you tell us, for those of you who don't know the name Steve Rockline, who is also known as Yoda, because he is one of the very original people that were on the Reluctant Brotherhood's telephone call back in 2011 when I started huddling with those guys. And there was Rob, God rest his soul, and Yoda, and a guy called James Rapp, and Teisberg. So I don't know if that's how you know him, Gary, but Yoda is pretty active in the state of Minnesota with various prostate cancer issues, and he himself has taken a very unusual timeline and treatment line, which we won't get into tonight because we want to hear about Gary. So Gary, why don't you tell us your story a little bit?
Well, the reason I know Steve is because I can't recall exactly how I found the Minnesota Prostate Cancer Coalition group, but I encountered it roughly in about the summer of 2016. And that was the year that I was diagnosed with prostate cancer. And actually, it was found more or less by accident. It wasn't something that was being actively sought after, I guess is one way of putting it. It's probably not unusual for people to find out sort of that they have it, and it's done because something else was going on at the time, and it just got picked up. And so, you know, I'm very uneducated at the time. I think I'm not unlike a lot of people that we find who come to the meetings if they find a way to them. Upon initial diagnosis, there's generally a lot of fear and anxiety, and you're not well informed. And from that perspective, you make decisions that maybe could have used a little more information at the time. And you're just this side of panic, so you want to address it as rapidly as possible and theoretically move on. And so in the November of 2016, I had a radical prostatectomy, and I'm probably one of the real fortunate ones because post-surgery, my urologist who did my surgery, who's pretty well known in these parts, said to me, you know, you're one of the few people I probably have the opportunity to say this to. He said, I think we may have cured you. And I subsequently know that I don't know if you're ever cured of it at the microscopic level, but since the surgery, and I had no follow-up treatment, I had no hormonal therapy, I had no radiation treatment. They felt that they had gotten it all. And subsequently, I've been undetectable. So now we're November 2019, so it's 3 years. I'm almost out 3.5 years. And I've had other follow-up issues, you know, sexual dysfunction, Peyronie's disease, which I'm currently struggling with. But And what was interesting about it was sent my prostate tissue samples out to Johns Hopkins for analysis. And the initial scoring that came back after the surgery was Gleason 8. And then when I went out to Johns Hopkins, the physician's name out there is escaping me momentarily, but that it came back as a Gleason 9. So it was considered pretty aggressive. And, you know, I had some concerns about that. And eventually my urologist was willing to order a genomics DX test on the cancer itself. So I had the test done. And it's interesting because, as it turns out, I'm not sure how big the sample set is in the group that I occupy as far as genomic testing is concerned. But if you take 10 people in my group, 7 out of 10 are considered high risk. 2 are considered moderate risk for recurrence. And 1 is considered at low risk for recurrence. It just so happens I happen to be that 1. So that was exceptional news for me. And my hope is that I remain in my current state. And the longer I do, the better off things are in general, just because as I get better educated about the subject of prostate cancer, there are some really exciting things that are over the horizon in the not too distant future. And being in Minneapolis, Minnesota, there's a lot going on at the University of Minnesota in terms of their cancer research program. And Kennedy has brought in some really brilliant people in the last year to run the program here. And I'm hoping that if there, in my case, if there ever is a recurrence, I will have some very targeted therapy available to me that I can access that will keep me, you know, long and strong until some other natural causal factor enters the picture. But, you know, you don't, until it happens to you, you really can't appreciate what it does to you and how it affects you mentally and emotionally, physically. And what I've gathered from it is that it's so important, and maybe it's now starting to happen, where people who are diagnosed initially get hooked up properly with adequate support. Because without that, they cannot make the kind of decisions for themselves that they need to make. And Rick, you said nobody can be a better advocate than yourself for yourself. And you can only do that if you're adequately educated about the disease, where you're at, and how you can proceed with whatever array of treatment is available at the time. And, you know, since I've been diagnosed, several friends of mine have been diagnosed and treated. And I just had a friend of mine that I grew up with last Tuesday pass away from both advanced metastatic prostate cancer and COPD. So I think the one thing that I've taken away, and I tell people when I encounter them who are recently diagnosed, is don't panic, you know, don't panic. There's time to figure it out. And it really comes down to, are you willing to make the effort to educate yourself as well as possible before you start making pretty high level decisions about what you're going to do for yourself?
So I think we couldn't agree with you more. I'm not sure if you're aware, but we run 9, I
think it's 9 prostate cancer groups a month, going all the way from active surveillance to low and intermediate risk disease to this advanced disease. And then we have a group even for men who have advanced disease who are under the age of 60. So we have all the different focuses, and we would encourage any of your anybody you run across to call into the right group. And I think the objective of our groups are to make you your best advocate. We try to educate you so that you feel comfortable speaking up for what you feel is the best treatment that you can get. And we hope that the guys go off the call feeling stronger and more empowered when they talk to their doctors. In your own case, congratulations. Well, first of all, I want to, just condolences for the loss of your friend. I just wish we could have had him on and navigated and guided him a little bit through his journey. Congratulations to you. I personally absolutely agree about the quality of the folks at the University of Minnesota, because I know Chuck Ryan personally very well. Have known Chuck since 2008 or 9.
Wow.
And I'm on first name terms, and he knows me very well. We used to live in the same town in Northern California. So yeah, he's doing a grand job there, and you're very lucky to have gotten somebody of that quality. And he is a name we frequently send people to if they're in the area. And I'm oftentimes in touch with him to let him know that we're shipping someone over to him. We would love to have you on any of our calls. You can listen to any of them. If you send me your email or sign up on our website, or even give it to me right now or put it in the chat window, we'll make sure you get on the list. I don't know quite which call to put you on for, but you are always welcome to come in to listen and to contribute.
Well, Rick, I really appreciate that. And, I sort of ride this roller coaster of periods where I'm more engaged, and then periods when I get busy and I'm not as engaged. But I think it's incredibly important. Not everybody can physically be present when we meet, for example, twice a month. There's a wonderful woman who recently attended. I go to 2 meetings a month that the Prostate Cancer Coalition puts on, and if I can. And there's a woman named Sarah Statler who has attended both of the different meetings. And she has an interesting history of how she found her way into providing prostate cancer support to prostate cancer patients. And she comes to it by way of her husband and her father-in-law, her dad and her husband's dad, both experiencing prostate cancer. But she is now actively creating post-surgical or post-initial diagnosis prostate cancer groups for urology providers. And there's, in our area now, Minnesota Urology is probably the biggest practicing group in the Midwest, pretty outside Chicago to Seattle at this juncture. But she's finally making some inroads into some of these providers where there's been almost an appalling lack of, in my case, for example, people who choose to have prostatectomies have no clue what they're in for once they've had it. And the preliminary information you get is rather spartan. And then post-surgery, typically it hasn't been a high area of interest for providers because they don't, well, if you get cynical about it, they don't make a lot of money providing full surgical support, right? But I think their attitudes are changing, and people like her are starting to, I think, win their.
It's a very tricky topic, and how the urologist stays involved after the surgery. A lot of pros and cons, but we have to finish up right now. We're about 5 minutes past our witching hour, but I would encourage your friend to call into Peter's call, the low intermediate call, because I think there's a lot of people on there who have had surgery recently and have the disease has not come back, but they're calling in maybe with issues of urinary issues, ED issues, or maybe none of the above. But that's really the call. So thank you for coming by, and spread the word. You heard, you can see what we do here. Guys, we will be back next week on Monday. Yes, on Monday, the 20th. Monday the 20th, and we will see you all then. And for goodness sake, stay safe. Please don't take any unnecessary risks. I think that was probably the big message that came out of today. We'll get this call posted. We'll post the chat window, and we'll talk to you next week, if not before.
Thank you, Rick.
Thanks, Rick.
Good night, everybody.
Good night.
Good night.
Good night,
Hi,
guys.
Rick. Thanks.